Hello, I'm Seth Kruger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, you can send us your questions or comments on Twitter at JAMA Network Open or in Facebook or YouTube in the comments under the video. We've got our first paper today, the effectiveness Iodophor versus Chlorhexidine solutions for surgical site infections and unplanned reoperations for patients who underwent fracture repair, the PREP-IT Master Protocol. And we've got first author, Dr. Slobodin here. Welcome.
Thanks for having me.
Sure. Did I pronounce your name okay?
Pretty good.
Okay, great. Thanks. So tell us a little bit about yourself and what you did here with the protocol.
Sure. So I'm an orthopedic trauma surgeon. I work at R. Adams Cowley Shock Trauma Center in Baltimore. I'm an associate professor of orthopedics in the School of Medicine at University of Maryland. And I'm one of the principal investigators on the PREP-IT program. And as I'm sure we're going to get into pretty quickly, the PREP-IT program actually is a master protocol that governs two sister trials, what we call aqueous PrEP and PREPARE. So basically, the PREP-IT program really is this overarching program that we put together to try and answer the question that you mentioned, iodophors versus chlorhexidine.
Okay, great. So reading through this, this is a pretty detailed protocol. There's a lot of stuff going on. It looks like it's two different RCTs together with a bunch of different things going on. Can you paint us the broad brushes here?
Yeah, I think the key comparison, as you mentioned, is the iodophor or iodine versus chlorhexidine active ingredient in the two most common antiseptic skin solutions that we use right before surgical incisions. And so that was the key component. But very quickly, you learn that actually those solutions can either be in an aqueous-based solution, like a water-based solution, or an alcohol-based solution. So you end up sort of with four potential treatments. And as we started going through those algorithms, both of, should we be doing a four-arm trial, which ones are actually being used regularly, it just made a lot more sense to split them up into two comparisons, two separate trials, and then kind of go from there as the different subpopulations reflected clinical practice.
Okay. And then similarly, you're doing cluster randomization with crossover. Can you explain what you're doing there with the different sites?
Yeah. So, we've done a lot of regular parallel randomized trials where you randomize at the individual patient level. And that's great from a statistical efficiency perspective, from a trial design perspective. But when you're in the trauma business, sometimes it's very challenging to try and get patient consent to participate in a study right before the intervention, right before some sort of emergent or urgent surgery. And so, we certainly looked at different methods of trial design and consent and realized that, perhaps this is an intervention that patients never really even know about that's happening, happens for every single patient, and maybe alternative study designs would make sense. And the cluster design is really nice in the sense that the hospital or the orthopedic practice treats everybody the same way all the time. And so it makes it very easy to implement the trial. But there's challenges with that design because if hospitals are different, which pretty much every hospital has some differences in it, you may not be able to determine whether the differences you see in your outcome that you're interested in are due to the actual intervention or just the case mix and differences between the hospitals. So you can do a cluster design, which the hospital will do the same thing every time, and then you can cross over and then have the hospital do the opposite intervention. And so that's what we're doing. All the patients get treated with one solution for a period, then the hospital switches over, and then all the next set of patients get treated with the other solution.
Yeah, and I found that really interesting when I was reading through this. That I'm not a surgeon, I'm an emergency doc, but there's a lot of face validity there. That I guess as far as getting internal validity, that you're actually doing it kind of optimally each time, and you're getting into the rote routine of properly using the solution instead of like, wait, which are we using today? Oh, it's this one, not that one, and not doing it right. Does that sound about right?
Yeah, no, absolutely. It makes it very easy to implement.
Yeah.
And as a background, is there a standard of care, I guess, in terms of either hospitals or surgeons using iodophor versus chlorhexidine, or is it sort of a variable practice, would you say?
Yeah, I would say there's still quite a bit of variability in the practice, and we did some groundwork in terms of surgeon surveys amongst our networks and things like that to get a better sense. There's definitely a lot of variability. Chlorhexidine tends to be, I think, more common than iodine solutions, particularly in closed fractures. But as you go to open fractures, that split really does shift more to an equal split. And I think some of the reason for that was, the literature probably in the 10 years before was really sort of mounting to suggest chlorhexidine may be better. And I remember, even in my surgical training, we were always using regular betadine, as people would call it, povidone iodine in water. And then all of a sudden, a couple of landmark papers came out in the early 2010 sort of era, and we just switched overnight. And when you dig more into those papers, they don't really reflect the orthopedic fracture practice. In particular, most of our infections actually occur, even beyond 30 days. And we're putting in orthopedic implants, which are very prone to bacterial biofilms and things like that. So you could very quickly realize that maybe the previous literature doesn't actually guide us in that decision very well.
And was that just previous literature from other type of surgical specialties?
Yeah. Most of that literature is in the abdominal surgery or gynecological surgery, cesarean section type stuff.
Yeah, and again, I'm not a surgeon, but I think again, there's some pretty clear reasons. The infections, the trauma from broken bones and the soft tissue versus GI bugs getting spread around incisional sites seems very potentially fundamentally different here.
Yeah, and I think if you look at the baseline infection rates, that should also probably clue you into the fact that our patients are a little different than other surgical patients and even arthroplasty patients. So patients that go in for a routine planned hip or knee replacement, the infection rate's less than 1%. Whereas closed fractures is about 3.5%, and open fractures about 10-12%. So there really is a difference in the injuries and the fractures that we're treating.
Yeah, so I have to say, so I'm infectious disease, and so I really appreciated the fact that you differentiated and you spend some time talking about open versus closed fractures, because there really is a difference, at least from an infection perspective. And I actually found it very interesting that the survey, and I think this is a survey you were alluding to, talked about the fact that the practices in terms of the antiseptic skin preparation were very, very variable for open versus closed. I just found that kind of interesting. I didn't know that.
Yeah, the surgeons often have a little bit of their own sort of voodoo, like I must always clean the skin with a 2-inch Curlex or things like that. So there is definitely some practice variability there. But the thing that is consistent is that we use one of these antiseptic solutions right before making the incision. And you always have to choose one of those two solutions. And that's really what drove the comparative effectiveness question.
Yeah, and what it's your table 3 is interesting. It's a little too big for us to show on the screen, but based on the estimated effect size, what your predicted sample sizes need to be. Can you talk about just kind of logistics? How big do you think samples are going to need to be? How long is it going to take? How many centers are you going to have?
Yeah, so I don't have it right in front of me because I'm trying to focus on the screen here. But no, I'm fairly familiar with them, and I think they're actually a really good exercise in reminding all of us when we try and do clinical research how small event rates and variable effect sizes really can change the required sample size. And when you look at all the previous literature, even the big landmark studies that I was talking about, they were hovering in around 800 patients, 1,000 patients. And, we're looking to get 1,600, 2,000, 6,500 patients in the different patient populations. We're hoping that the entire program, recruits approximately 10,000 patients. So much bigger magnitude. We're really hopefully dial in the precision on the estimate there.
Good to welcome a couple of viewers. Nicole Silva, Eamon Grad, and Ahmad Khaled have joined us. We're talking about trial protocol for Iodophor versus chlorhexidine for fracture surgeries. So how many sites do you have, and how long do you think it's going to take to recruit all these patients?
Yeah, so we have over 25 sites. As you mentioned, there are 2 separate trials. So most of the sites are, of course, only participating in one of the trials, just purely from the feasibility of implementing different solutions. But over 25 sites, aqueous prep started earlier. by maybe 6 months or so, and is actually 75% towards its recruitment goal already. So its minimum recruitment goal. So we have over 1,200 patients already enrolled in APREP. Prepare is about 50%, so also doing very well. 700 open fracture patients, 3,200 closed fracture patients, and it's really a huge credit both to the 25 sites that we have. We have well over 95% follow-up for the primary outcome. And then, of course, if you flip that around on the management side, to manage 2 large trials at the same time with that many thousands of patients of data, the Method Center at McMaster is just doing a phenomenal job. And I'm not sure that anybody else could have pulled that off other than them.
Yeah, absolutely. All right. Any other final thoughts?
I think the study design, of course, is very unique with the crossovers and stuff. But the other thing that's been really, really unique is the patient engagement that we've had from the beginning. And, PCORI is one of the funders, but also just the fact that PCOR in itself as an entity was new to a lot of us. We try and ask patient important questions, but we don't necessarily have the patient involved right from the beginning. And that's really what we did. And Daniel Mullins and the patients group really walked us through that. And we had our patient partners that continue to be at every meeting, vet every single decision we made. And for me, the take home has been, every time we do a study, there's some things you have to decide. You have to make some decisions about the study design. And when you don't know the answer, rather than making it up, why not defer to the patients who are actually going to be affected by this instead? Let them decide. And that's been a huge plus for the trial.
Yeah, that's great. Well, great. Well, thank you. Thanks for joining us and talking about it. This seems like great work, and looking forward to seeing the results.
Awesome. Thanks again for having us.
All right.
Take care.
Absolutely. Take care. All right. So next up, we have the differences in stage of cancer, diagnosis, treatment, and survival by race and ethnicity among leading cancer types. This is by Zhang and colleagues. Sorry, let me pull up my little page here. So this is interesting. So this is patients from the SEER cancer database from 2004 to 2010 with 5 years of follow-up. So 950,000 patients. Kind of wish they would went another 2 months just to get over 1 million, just to get a nice round number. And really just looked at a bunch of different things that happened when patients were first diagnosed and then treated, and how much survival was by racial breakdown. It's really interesting stuff. There were with big databases like this, some of the information, you're going to have huge numbers to find small differences. So a few years difference in age. I think the white patients were like 65 on average, and the black patients or Hispanic patients were 61 on average. A couple other small differences and kind of details like that. Some of the important things that I think were interesting were metastasis diagnosis. And this is the kind of thing where I don't think a lot of this information was surprising, really, but kind of, I think, reiterates a lot of the disparities that we know in our healthcare system. But if you look at table 2, so in this one, Asians the reference group, and lower numbers are kind of better or healthier outcomes. So white patients had, I guess I'm going to use bad words, but trend towards lower rates of metastasis diagnosis, and black patients had higher rates of metastasis diagnosis. And definitive treatment was kind of the opposite, where the odds ratio for black patients in the database was 0.63 for definitive treatment, which is pretty shocking. Pretty big difference. Hispanic similarly 0.75. Pretty decent differences. And then table 3 shows hazard ratios for cancer-specific survival and overall survival. And again, not surprisingly, the vulnerable minorities where there's health disparities did worse here. Hispanic patients had a hazard ratio of 1.3 with basically 30% or 28% worse overall survival, and black patients were 1.75. So basically, I don't know, substantially increased risks of dying of cancer. And there's so much wrapped into this as far as comorbidities, access to care, all sorts of things, and a lot of other interesting details of the study.
Yeah, no, I agree. And, as you mentioned, there's so many things that could kind of play into some of these findings. I thought the magnitude of differences was pretty interesting for some of them. I also kind of appreciate in the discussion, they say that there are a lot of things that, a lot of factors that contribute to these findings, but they do note a few studies that actually have found that the risk among Black patients receiving delayed and non-standard treatment is substantially elevated, and that may be one factor that plays into it, which I think, as you said, sort of reiterates things that we know in thinking about health disparities. But when you see studies like this on a large scale using large databases, it really kind of highlights those issues more, I think.
Right. And I think that's something also that the COVID-19 experience has really shown us. There's been a bunch of good data, a bunch of headlines about how Black people are more likely to get coronavirus infections and more likely to get critically ill and die from them. And a lot of people, I think a lot of people smarter than me who know this issue and can talk about it more eloquently than I can have mentioned, have point out, it's not that, this racial difference in how you're susceptible to disease. It's structural racism making you more likely to get it, less likely to get good healthcare for it, more likely to have comorbidities that make you more likely to have a more serious disease, et cetera.
Oh, absolutely. I agree. Yeah. So very interesting.
Yeah. So on that happy note, what do you have next?
So this is a little different. This is an association of regional practice environment intensity and the ability of internists to practice high-value care after residency. So this study was trying to look at the association between healthcare intensity in the region where physicians practice, internists practice, and their ability to practice high-value care. So they sampled 3,800 about internal medicine physicians who took the 2002 ABIM, which is our sort of certification exam. And then they kind of defined intensity of care in what was called the Dartmouth Atlas hospital referral region. And they measured this. Is sort of interesting, just getting a little bit into methodology here. They measured this by per enrollee end-of-life physician visits and current practice type. And then they measured a physician's ability to practice high-value care using something called the appropriately conservative management score on the mock exam. And it's just basically is the way that you answer certain questions on these exams that kind of puts you into those categories, which I didn't know about. I thought that was kind of cool. And so what the study found was essentially those that providers that moved to regions in the quintile of highest healthcare intensity had these ACM scores, the appropriately conservative management scores, that were lower than internists who moved to regions in the quintile of lowest intensity. So essentially what they were saying is that practice patterns of internists who relocate after residency appear to migrate towards the norm of the region that they're practicing in, which sort of like intuitively I can understand that, but it was sort of interesting to see. I thought the methodology was very kind of unique here and kind of cool.
Yeah, figure 2 kind of shows that graphically, and it's I don't know, it's one of those things where, again, it's easy to explain things in hindsight, and I might be totally wrong.
Yeah.
But I feel like there's so much like socialization into practice of wherever you're practicing. So, I think that the way that you're trained during residency definitely, sets up a lot of your practice patterns overall. But it's kind of what your colleagues and friends are doing, and it's not just necessarily, I don't know, abstract things like socialization, but some of it's subtle things like we a while ago set up an outpatient stress pathway for chest pain in the ED, and suddenly it's a lot easier to do, to not admit patients for chest pain. If it's easy, I'm in a hospital where it's pretty easy to get an MRI. I order a lot more MRIs than I used to. So these systems things matter. Ernest has joined us as well as Lindsay, O'Hara, and Luca. Welcome. I also found it fascinating. I was kind of impressed that almost 3/4 of docs leave their hospital referral region. I mean, based on my kind of like casual experience, a lot of trainees stay around.
Yeah.
So I found that really interesting.
No, I did as well. I mean, so I appreciate your point, but I also wonder about, I feel like initially people do sort of practice the way that they were taught. At least, when you think about academic centers and, people that are moving from one area to another, there's always this kind of discussion about like, well, we used to do things this way, or like, because this was more available, we did it this way, or this was just sort of the culture. And so I always thought you kind of take that culture with you, but I can also sort of appreciate that over time you probably do kind of adopt whatever is the the standard or the norm in the place that you're in as well. So I don't know.
Yeah, no, and I've been at different places for med school, residency, fellowship, and then 2 different faculty jobs, and it's been it's been interesting to me how I think for people who've only or who stay local for either just that's where they are in their career or for a substantial amount of their career, there's, I think, this undercurrent of this is the way things are done, not this is the way we do things here. And it's really interesting to me just how variable practice is at different places. And a lot of it's, we don't have great high quality data on everything, and there's more than one right way to do a lot of things.
Yeah, that's true.
Yeah. I don't know. That's my take on it anyway. It's also interesting too, because I feel like there's so much. I mean, I'm not an expert on board certification and tests and how rigorous these are and things, but I could see like in emergency medicine in general, the research exam at 10 years is I don't know, the general word is like, you have to study what you're going to pass.
Right.
and so, I don't think there's, necessarily a correlation between your score and anything meaningful.
Yeah.
It's really pass fail. So it's hard to know, but this is really fascinating stuff. I don't know. It's also great with stuff like this for the level of evidence where there's enough detail to hypothesize about a lot of things, but nothing to prove anything right or wrong.
Right, exactly.
All right. Nice. All right. You got one more for us?
Yeah, so this is timely. This is clinical characteristics of patients who died of coronavirus disease 2019 in China. This is a research letter, and it's essentially a case series. It's trying to understand the characteristics of 168 patients who died of COVID-19 in Wuhan, China. This was data that was from a period of time in January. And they ultimately had 75% of those who died in this sample were men. The median age was 70. 95% of patients were older than 50 years of age. 74% had one or more comorbidity. Hypertension was the most common comorbidity, followed by diabetes and ischemic heart disease, which is all stuff that I think we kind of, as we're seeing more with these patients, I think this really falls into the sort of the epidemiology that we all are starting to learn. The other things that were sort of interesting, I thought, was they looked at patients that received some sort of, they looked at the oxygen therapy that patients received. So all of them obviously, received oxygen therapy. 42 patients received nasal or face mask. A third received high flow nasal cannula, or high flow nasal oxygen, I should say. 72 received non-invasive ventilation, and then only 20% of patients were intubated and received mechanical ventilation, and 1% received ECMO. And one of the things that the authors talk about briefly is that delayed intubation was common in this sort of earlier stage of the pandemic in China. And so, I know there's been a lot of discussion about this now, about kind of timing, et cetera. So I thought that was sort of interesting.
Yeah, it's really fascinating. I mean, I think this is one of the things where it's really informative, especially with how dynamic our understanding is of coronavirus. So it's so easy to kind of look in hindsight and say, like, were we doing the wrong things before? But we're learning so much. It's only been really about a month in Chicago that we've had COVID cases. And, initially it was these patients die of hypoxia. Like the trajectories are fast. As soon as there's 5 liters of oxygen, intubate, because they're going to do badly. And then, I mean, kind of like they're showing here, 1% of patients getting ECMO, that it seemed like there wasn't even a window to identify who could benefit from ECMO. So we have no idea if it's actually going to help anybody. But now the pendulum swung back to, trying to do high flow nasal cannula or awake proning and other not less invasive interventions. But it's hard to know. And, these are the observational studies where it's so hard to know. It's a lot. It's so, these really describe what happened and not what should have happened.
Right.
Yeah, no, it's tough. And there's also so much hand-waving physiology about, the ACE receptors and hypertension. And I mean, I'm fascinated because, in the last couple of years, Ang2 has become really popular in ICU. And now there's this virus that modulates angiotensin receptors. And is that good that we're using Ang2? Is it bad that we're using Ang2? Well, we just don't know. There's a ton of open questions here.
Definitely. More to see, I guess. So we'll learn.
Yeah, absolutely. Yeah. So it's really fascinating. It's also kind of, I mean, I think really reassuring to see, in the middle of this big pandemic, we're still kind of, taking the time for people to report their experiences to share with other people, as well as, go through the processes of peer review and publication and, keep up the rigorous science, because it's so easy to just kind of go based on anecdote and, word of mouth on this stuff. So.
Yeah, absolutely. I agree.
Yeah. All right, great. Well, that is all we have for today. Of course, join us next week, April 21st at 3 p.m. Central Time. Follow us on the usual social media channels. Get these papers and more at JAMAnetworkopen.com, where everyththing is full text and free and open access. And of course, we have new content every weekday, 10 a.m. Central Time. So thanks for joining. Stay safe.
Thanks, everyone.